Today we are here for our ECHO discussion on palliative care emergencies. Do you know what to do? And this is a standalone series, which you will receive a follow-up email from Laura with regards to all of our details. You'll have a link to the recording, you'll have a copy of the slides, and any relative tools. On that note, we will be sharing some tools and links in the chat, but if you miss copying them, don't worry, we will send them out to you by email as well. And before we get started, I'm actually going to do a land acknowledgement. I've recently rewritten my land acknowledgement because it's a little bit more personal for me. So I wanted to share this one with you. I acknowledge that we are on the traditional territory of the Indigenous peoples, including the Anishinaabe, Haudenosaunee, and Wanda nations, on the land known as Turtle Island. We honor their enduring connection to this land and recognize the treaties made here. As we gather, I commit to continuing on the road of learning and ensuring that my children and their children are educated on the true history of this country and the rich cultures of Indigenous people, including First Nations, Métis, and Inuit. Together, we strive to support reconciliation, respect, and justice. And we can begin our presentation. So, you all know we are here for the Palliative Care ECHO project. If you are looking for more information on the greater ECHO project in a whole, you can visit their website at echopalliative.com. And we would like to send out a special thank you to Health Canada for their financial contributions, making this project feasible. And our instructors today. Today we have with us, and if you've been with us before, you are very familiar with Laura and Linda. Laura and Linda are both from the North Simcoe Muskoka Hospice Palliative Care Network, and they are fantastic individuals, and they put on a great presentation. Without further ado, ladies, the floor is all yours.
Thank you, Amanda. So as Amanda said, my name is Laura Bates. I'm a registered nurse, and Linda and I hold the education and coaching portfolio with the North Simcoe Muskoka Hospice Palliative Care Network.
Hi, I'm Linda, and I'm Laura's partner.
Partner in crime. So let's talk about palliative care emergencies, Linda.
Okay, thanks everyone for joining us today. And here's a code that we would like you to scan if possible. You can either do it now or at the end of the presentation. It will take you to a satisfaction survey that we ask that you fill out, that we can have some feedback to make our ongoing education, up to date or change a few things. Whatever we see in the feedback, we try and incorporate. So the learning objectives for today's session are that by the end of the session, we would hope that you will be able to describe the most common palliative emergencies, know how to prepare other healthcare workers and patients and their families when there's a risk for a palliative emergency, and use both pharmacological and non-pharmacological interventions to handle palliative emergencies. So palliative emergencies can also be called medical or oncological emergencies. Sometimes these terms are used interchangeably. And with advances in medical research, treatment, and technology, life expectancy across the world is continually increasing, and so is the proportion of the elderly among our population. And as the population ages, the number of people living with end-stage cancer and terminal illness continues to grow. As patients near the end of life, they commonly present themselves in the emergency department, either for symptom control or the treatment of palliative care emergencies. According to the Canadian Institute for Health Information in 2023, almost 1 in 4 patients receiving palliative home care were transferred to the hospital at end of life. Next slide, please, Laura. Palliative care emergencies can occur at any time during the illness journey, but are more prominent in advanced disease sites. Palliative care emergencies can significantly impact a patient's remaining quality of life and be deeply distressing for their caregivers. It is important to discern which patients are at risk for palliative care emergencies, so that in these circumstances, the patient's wishes can be ascertained and the response required to meet the patient's wishes can be discussed and incorporated into their plan of care. Next slide. We have several types of palliative emergencies that we're going to discuss today. It's an overview. It is not an in-depth presentation. We'll be going fairly quickly through the slides, and there'll be some extra information on the slides as we go. So types of palliative emergencies that we'll be discussing today are airway obstruction, airway hemorrhage, massive GI bleed, massive bleed from other sources, which could be wounds or fungating tumors, intractable seizures, pulmonary embolism, neutropenic sepsis, pain crisis, spinal cord compression, superior vena cava syndrome, hypercalcemia, and malignant bowel obstruction. Other symptoms such as agitation, seizures, and emotional and spiritual distress may need urgent care. However, we won't be talking about those today. Next slide.
Thanks, Linda. As Linda said, we are going to, and if there's something that you want to see in more depth at a later date, please let us know in the feedback survey and we can possibly do that as one of our future topics. First, we're going to go over airway obstructions, dyspnea, and hemorrhages. Now, there are multiple common causes of airway obstructions, and up to 80% of all patients will experience shortness of breath in the last 24 hours of life. In lung cancer patients specifically, 20 to 30% of them will develop airway compromise or full airway obstruction. And this is a very serious and scary event for both the patient and their family and caregivers. The management of severe dyspnea or an airway obstruction always has to be done in the context of the patient's goals of care, their prognosis, their comorbidities. How we manage it in someone who has PPS of 60% and is undergoing chemotherapy with the goal to cure their cancer might be very different from how we manage it with someone who has a 20% PPS, has a prognosis of days to weeks, and who wishes comfort measures or symptom management only. It's also really important to determine whether the airway obstruction could become a catastrophic event and plan accordingly with health teaching, appropriate medications, and ensuring that any interventions line up with the patient and family's goals of care. When it lines up with these, we should also be considering treating any underlying cause in addition to managing these symptoms. So although it is statistically rare, hemorrhages that become catastrophic are a situation which can become life-threatening very quickly and are extremely distressing to all present and involved. Up to 10% of patients with advanced cancer and about 3% of patients with lung cancer specifically will experience a terminal bleeding event. That's a significant number when you think about it. Those with liver disease are also at extremely high risk because of the impacts of blood clotting ability and variceal bleeding. If a patient has been prone to having small episodes of bleeding, it should be considered a warning flag and red flag that there is an increased possibility of a larger bleed. A clear plan of action needs to be developed and all members of the team informed. Just a quick reminder that a patient does not need to have bleeding from an external source in order to have a catastrophic hemorrhage. It could be from the respiratory system, from their GI system, or from the genitourinary, that's one that's going to give me trouble today, systems, bladder, or sexual organs. And if in large amounts, it will only be a few minutes between when it begins and when the patient loses consciousness from the loss of blood volume. It's also possible to have a catastrophic internal bleed, which will lead to hypovolemic shock, loss of consciousness, and then death, but without the external signals that there is bleeding happening. When a hemorrhage is in an airway, it can be especially distressing because of the added dyspnea that comes with it. The best plan for management of this type of hemorrhage is to have a plan in place ahead of time. The plan should include the discussion and review of goals of care, resuscitation status, and what the patient wishes to happen. For example, is calling 911 appropriate versus medication or symptoms for the symptoms and sedation. Health teaching needs to be completed to all that are involved, any patient's family or caregivers, any healthcare providers, anybody who interacts with the patient, that they're aware of what to do, who to call, and when possible, a plan for debriefing and support should be made ahead of time under the assumption that it is going to happen. Black towels, dark bedding, a basin, disposable absorbent pads are some of the equipment that needs to be on hand, and it needs to be very close. It does not need to be down the hall. It should be in the room or immediately outside the room. The patient should be placed in the recovery position to allow for the blood to drain when possible. It's also vital that appropriate PPE is on hand, that it can be grabbed as staff are attending or family. If the medical team feels that the likelihood of a catastrophic airway hemorrhage is high, then having appropriate sedation orders and medication on hand ahead of time is vital. If possible, even having the first initial doses pre-drawn in syringes ready to go will help. That is especially important if the medication is going to be administered by family when the patient is at home for end-of-life care, because you don't want somebody having to remember how to drop a medication and then administer it while panicking. The most important thing in any of these is to make sure that the patient is never left alone unless it is absolutely necessary, because there's nobody else to gather supplies or to make phone calls. And whoever responds first should be delegating to other people to do those tasks, whether it's gathering the supplies or calling a doctor or nurse practitioner. Catastrophic hemorrhages from any source are managed roughly the same way. Ensure that thorough health teaching is completed ahead of time. Make sure the supplies are close by, and appropriate medication orders and medications are available, and ensure that the patient is not left alone. If a bleeding event is not catastrophic, then the most responsible physician or nurse practitioner needs to be notified as soon as possible that a plan can be made. This is especially important if it's from a wound or fungating tumor, which is slow to stop bleeding or does not seem to stop at all. The most commonly used medication for sedation in a situation like this would be midazolam, and the dose is dependent on the degree of symptoms and the required or desired amount of sedation. If it is not a terminal event, other medications may be used, such as nausea for GI bleeding, something for anxiety, and something like an opioid for dyspnea and or pain. If a patient's on anticoagulants, it's obviously very important to hold those doses and reevaluate with the most responsible physician or nurse practitioner. Back over to you, Linda.
Thank you, Laura. Most seizures are self-limiting and require only supportive care. However, if they are ongoing and last greater than 2 minutes in duration, and the patient does not recover consciousness between seizures, they require prompt emergency treatment. Seizures in the palliative care context can occur in about 13% of cases. That's quite a few patients. And seizures can be caused by either structural damage or by a systemic insult. Next slide. When a patient develops a seizure, a prompt history and physical examination are useful to determine the cause. Anticonvulsant prophylaxis is not recommended in patients with brain tumors, whether primary or secondary, if the patient has never had seizures. Patients should take dexamethasone before, during, and immediately after cerebral radiotherapy to prevent the edema secondary to acute radiation toxicity, which could provoke seizures. And obviously, if the patient's in status epilepticus, then obviously you're not going to have much time to do much of an assessment and a history. So that would have to be treated first. The treatment of seizures will vary according to the frequency of the convulsive episodes. For status epilepticus, lorazepam is the drug of choice for its speed of activity, duration of effectiveness, and ease of administration. Midazolam is a good second alternative, and phenobarbital is the third choice. Patients should be positioned in such a way they cannot hurt themselves, the airway should be maintained, and oxygen should be supplied as necessary. Next slide, Laura. Neutropenia is an abnormally low concentration of neutrophils in the blood. Obviously, we know that neutrophils are a type of white blood cell that works as part of the immune system to fight infection. Patients with neutropenia are more susceptible to infections, and without prompt medical attention and treatment, the condition can become life-threatening. A patient's absolute neutrophil count can decline as a cancer patient direct result of disease. However, neutropenia is most commonly seen as an effect of cytotoxic therapy. For the majority of cases, the nadir in the absolute neutrophil count occurs 5 to 10 days after the last dose. After the last dose of chemotherapy, we should be cognizant of blood work to see what the absolute neutrophil count is and keep an eye on this because, as mentioned, it is a life-threatening and emergent condition. Next slide, Laura. Infection is responsible for at least half of the cases of neutropenic fever. And fever can be an oral temperature of over 38 degrees for one time, when you take it one time or in succession, and a patient's reduced ability to fight infection may have localized signs or may not. It is imperative that one watches for fever, as this may be the only sign. When the absolute neutrophil count is less than 500, the patient is considered neutropenic. If the patient arrives for blood work and the absolute neutrophil count is 1,000 and it's expected to decline, then they should also be considered neutropenic. So a careful examination is crucial, and blood work should be done as well as 2 sets of blood cultures. If a patient has an indwelling device or an IV, then obviously blood culture from the device should be taken to see if there's anything growing amongst the catheter, and usually this is one of the causes. So 2 sets of blood cultures, and watch for the blood work to come back. In the meantime, empiric antibiotic therapy should be initiated, and then coverage with the antibiotic should be narrowed as the blood culture data becomes available. Again, lots of health teaching to the patient, to the family about neutropenia and when it's necessary to present at the emergency department. Okay, Laura?
Thanks, Linda. So although a pain crisis is not a life-threatening emergency, it is an urgent situation that should be considered an emergency in palliative symptom control. And to manage this, we want to use opioids to bring it back under control and get it out of that crisis situation. Once we're out of the crisis situation, we need to ensure that the routine and breakthrough medications are optimized. So is the patient using the appropriate medication, and are they using that medication appropriately? Maybe this involves adding adjuvant medications, changing the route of medication, and even considering the use of a pump for continuous infusion instead of intermittent injections if they're already getting it subcutaneously. We always want to add any non-pharmacological interventions and complementary therapies that are helpful, and seek out the assistance of a pain or palliative specialist if required. Pain in itself may be a symptom issue, or it might be the symptom of a further palliative emergency, such as spinal cord compression, amongst others. For more information on assessment and management of pain, Amanda's going to put a link in the chat to our pain series that we previously did. If someone has poorly managed pain and it becomes intractable, then palliative sedation can be considered as a last resort method, and only if it's clinically appropriate and fits with the patient's goals, wishes, and desires. And that's just a list of the management. Just a reminder to always look for easy to fix causes of a change in somebody's pain. Been more than one time when I was a visiting nurse that somebody's pain pump tubing was clamped or kinked and it hadn't been noticed. Just remember those little things can sometimes be a problem. Spinal cord compression. Metastatic or malignant spinal cord compression is a palliative and medical emergency that requires urgent medical attention that aligns with the patient's goals of cares. In this situation, a tumor is damaging or compressing the spinal cord, either directly or indirectly, interrupting its ability to send messages between the body and the brain. It's most common in patients with breast cancer, lung cancer, prostate cancer, and multiple myeloma. Should be noted that if patients have metastatic disease to the spine, 10% of them will develop a spinal cord compression at some point in their illness journey. Early symptoms are often described as back pain that worsens over time, that gets worse when laying down or that worsens with coughing, sneezing, or straining. There might be complaints of progressive weakness of the arms and legs, or complaints of changes in sensation or pins and needles. Later symptoms can include urinary and or fecal incontinence, changes in sexual function, and changes in the ability to walk, stand, or weight bear. Without treatment, these effects can become permanent and significantly affect a patient's quality of life. When it's suspected, the most responsible physician or nurse practitioner needs to be immediately informed. It's best if the patient can lay flat on their back if tolerated with little to no movement. If they're experiencing pain, that should be still managed as ordered. And again, that intervention and management will depend on the patient's goals of cares. This might include additional medications such as corticosteroids to reduce the swelling and inflammation and alleviate some of that compression. It may include surgery and or radiation treatment to reduce the size of the tumor. The goal, no matter what is picked, is to improve the symptoms as much as possible and or stop them from progressing and worsening. Additional assessments should be sought from occupational therapy, physical therapy, and psychosocial services to support the patient also.
Superior vena cava syndrome describes the compression of the superior vena cava and its tributaries with subsequent engorgement at the vessels of the upper trunk. The most common cause of SVC is malignant disease, and the major mechanisms underlying the development of SVC include 1, external compression by a mass, 2, occlusion of the SVC by invasion of a tumor into the wall of the vessel, 3, intramural thrombosis due to a neoplastic thrombus, and 4, intravascular thrombosis related to the pressure of intravascular catheter in a major vessel in the upper thorax. The clinical picture of SVC is due to venous hypertension in areas normally drained by the SVC and its tributaries. Malignant disease accounts for 80 to 90% of the cases of SVC. Without treatment, deterioration will occur, which will end in death. Cancers associated with SVC include lung and breast cancers and lymphomas. Next slide, Laura. The management of SVC depends on whether the onset is acute or gradual. With acute onset of symptoms, which was in the previous slide, and I must tell you that once you see an acute session of SVC, you will never forget it. If you can go just to the previous slide for a second, Laura. When they're in acute distress, they have periorbital edema, dilated neck veins, dilated chest and arm veins, arm and hand edema, increased respiratory rate, stridor, cyanosis, and papilledema. So with an acute onset, okay, we can go next slide. With an acute onset of symptoms, interventions are directed at preventing life-threatening complications by maintaining the patient's airway and cardiac output. If the onset of SVC is more gradual, initial interventions are directed at symptom management and determining the underlying cause. In most cases, patients are treated with radiation therapy as first-line therapy, especially in acute SVC. The use of chemotherapy for SVC depends on the cause of the syndrome and the type of tumor involved. If SVC is a result of thrombus, then IV heparin can be used as a first line. And urokinase is the second line should heparin not work. Expandable wires and stents can also be placed in the stenosed or obstructed portion of the SVC. Again, if there's no intervention, this will result in death. Okay, next slide. Hypercalcemia will be experienced by 1/3 of cancer patients at some point in their disease course. Malignancy is the most common cause of hypercalcemia, with primary hyperparathyroidism being the more prevalent cause in the general population. Bone metastases does not have to be present to cause hypercalcemia and occurs as a result of a number of different mechanisms. Hypercalcemia of malignancy is a complex metabolic complication in which the primary defect is an increase in the bone resorption of calcium that exceeds bone formation and the kidney's ability to excrete serum calcium. The most common cancers associated with hypercalcemia include lung, head and neck cancers, breast, ovarian, prostate, bowel, bladder, renal cancers, myeloma, lymphoma, and sarcoma. And hypercalcemia is associated with a 50% mortality rate if not treated. As with other palliative care emergencies, treatment of the underlying cause of hypercalcemia is the most effective approach to the problem. However, in some cases, this approach may not be possible and symptomatic relief becomes the priority. Medical interventions focus on increasing the renal absorption of calcium, decreasing the gastrointestinal and renal absorption of calcium. Treatment with oral hydration is recommended for mild hypercalcemia, while intense hydration is used for moderate to severe hypercalcemia, along with agents that inhibit bone absorption of calcium. These are administered intravenously, and they include mostly the biphosphonates. Okay, Laura? Malignant bowel obstruction is common in patients with advanced abdominal or pelvic cancers, and it is the most prevalent in ovarian cancer, colorectal, and gastric cancers. Intestinal obstruction may be caused by benign or malignant etiologies. Benign etiologies are caused by non-malignant causes, and these include post-surgical adhesions, radiation enteritis, or other infections or inflammatory GI diseases. Benign conditions are commonly observed when the obstruction is in the small bowel where primary tumors are rare. Next slide. Clinical management of malignant bowel obstruction requires a specific and individualized approach that is based on disease prognosis and objectives of care. Surgery should always be considered in patients with initial stages of disease with a preserved general status and a single occlusion. Less invasive approaches such as duodenal or colonic stenting should be considered when surgery is contraindicated in obstructions at the single level. The priority of care for inoperable malignant bowel obstruction is to control symptoms and promote maximum level of comfort possible. Polymodal treatment is based on a combination of glucocorticoids, strong opioids, antiemetics, and anti-secretory drugs.
So in case you haven't noticed already, the theme of today's presentation is that to manage a palliative emergency, you need to be prepared. It's always about plan for the worst, right, Linda?
Mm-hmm. And we've seen it, Laura.
We have. All patients should be screened regularly for poorly managed symptoms, hopefully at every healthcare interaction, and ideally using a tool such as the ESAS, even if they don't typically have any concerns or complaints. And Amanda will pop the ESAS into the chat. Thank you, Amanda. Especially for some of the symptoms that could be a sign of a bigger emergency beginning, such as pain or dyspnea, because they're often underreported and then undertreated. So anyone with advanced disease and or poorly managed symptoms is at risk of having a palliative emergency, whether that's a symptom crisis or an actual catastrophic event. Although we didn't discuss it specifically in this presentation and the literature doesn't consider it an emergency, delirium is something that should be considered an urgent or emergent situation and warrants the same diligent screening, urgent response, thorough assessment, and management using both non-pharmacological and pharmacological interventions that line up with the patient's goals of care. And we previously also did a session on delirium, and I think Amanda's going to put the link to that in the chat. In order to be fully prepared, we need to understand who's at risk, along with knowing what the role of each person involved is going to be in responding to that emergency. Healthcare providers need to have honest conversations with patients and their families and caregivers about what the goals of care are, the likelihood of this specific emergency happening, how it should be or could be managed, and these conversations need to happen as much ahead of time as possible. Over the next slides, we're going to speak to how to deal with the palliative emergencies in a variety of care settings, but remember that this is in the context of Ontario, and legislation may be slightly different to your province or territory. And of course, always remember to follow the policy and procedures set out by your facility or employer. So if a patient is at home or in a retirement home, then all of the home staff, along with outside care providers that are coming in, should be aware of the risk, the type of the emergency, and what the interventions and plan of care is if that were to happen while they are present. This may mean ensuring that appropriate paperwork is completed, such as a do not resuscitate form or any other paperwork that's required for an expected death in the home ahead of time. It's vital that there's communication about early bleeding or other early signs of possible emergencies with the medical team. When possible, it's good to have appropriate medications such as a symptom relief kit or SRK in the home, and having those medications pre-drawn if family or caregivers are expected to administer them. It's also vital to ensure that family and patients receive the appropriate health teaching on these early signs and symptoms, how to be prepared, and what to do and who to call if something happens. In the hospital, it's not that much different, but we need to make sure that communication happens between team members and between shifts, and that all goals of care and resuscitation status, along with conversations about the emergency risk, are documented well in the medical record. If the patient is in a residential hospice setting, preparation is very similar. It's education for all involved, ensuring that the medication and orders are on hand, having required supplies nearby and easy to grab, and good communication between all members of the care team and the family and patient. And again, if someone is in a long-term care home or nursing home, the preparation is the exact same. Education, easy access to medication with the appropriate orders, easy access to the appropriate supplies, and excellent communication.
Understanding the fundamentals of palliative care emergencies is crucial in educating patients and their families. Education must revolve around a patient-centered approach that focuses on improving the quality of life of individuals. Pain and symptom management is the cornerstone of hospice palliative care. Patients and families also require emotional and psychological support. Education also forms an absolutely essential part of palliative care. Explanations of disease processes, treatments, and what to expect empowers patients and families to make informed decisions about their care. So we'll just go very quickly through the roles of a PSW, through a palliative emergency, and then nursing, as Laura has 3 case studies to present and ask questions. If the PSW is the first person to come upon a patient in distress, they should never leave the patient and call out to other staff via the call button or with their voice. They should remain calm in a calm tone of voice and reassure the patient that they are not going to be left alone. And depending on the emergency, if someone else is in the room that can stay with the patient, then the PSW can grab the exsanguination kit or anything that may be needed, such as black towels or basins. And they should continue to support the patient while the nurse is giving medications or call for extra support as needed. And then if the patient does succumb to death, then assist with the room and patient cleanup. If the nurse is the first person to come upon a patient in distress, they should not leave the patient and should call out or use the call button. As soon as someone else arrives, then either they go and retrieve the medication, or in any catastrophic event, hopefully they have been drawn up ahead of time and are within easy reach. Hopefully health teaching has already been done with the patient and their family, and obviously support of all of those involved in the event. And after the event, then consideration of a clinical debrief and documentation of the event. I don't think I'm going to go through these, Laura. There's a few more slides about
Okay.
pharmacological management and non-pharmacological management that you can read after when Amanda sends out the slide deck, or when Lori actually sends out the slide deck. And I'll just let Laura go ahead with her case studies.
Okay, thank you, Linda. Yeah, these are some good, I'm hoping these case studies will have some good discussion, and I'm sure there's at least one person in the audience who's been through one of these types of situations. Getting some feedback and firsthand knowledge from others is always good. Our first case study, before we start, I just want to say that all three of these case studies are based on real events that myself or my colleagues who helped with these case studies have been through. They will show the good, the bad, the ugly, the right, and the wrong way of handling things. So please just keep that in mind that these are real situations. Our first is a 39-year-old female who has a terminal diagnosis of liver cirrhosis and esophageal varices. And she also has a large gastric ulcer that's bleeding actively. She's in the ICU currently. Her previous treatment of the bleeding varices was unsuccessful. She is having intermittent bloody emesis, abdominal pain, and constant nausea. Blood transfusions have been ineffective in raising her hemoglobin. She now has a do not resuscitate or DNR ordered. And her current treatment includes oxygen by nasal prongs, an IV continuous infusion of Pantaloc, daily blood product infusions based on blood work, and an IV of normal saline to try and maintain her blood pressure. I'm going to ask a few questions. I would love if you could unmute and give answers to the questions, or pop them in the chat if you're not able to unmute and speak. For this first patient, is a hemorrhagic bleed the only palliative emergency that she's at risk for?
No. Obstruction.
I heard no. And what was that second part, Kathleen?
Obstruction.
Yeah, she's at risk of an airway obstruction. She could aspirate on the blood or a clot. There's also a possibility that there may be erosion from the varices into the lung tissue or the tissues surrounding the lung. Besides the do not resuscitate order, what else should be discussed with the patient and the family or the patient's substitute decision maker? And there's lots. Just shout them out.
Goals of care, palliative sedation.
Yep, I see goals of care in the chat.
What to expect, what might happen.
Yep, very important. We want to make sure everybody's aware of what this could look like and what she's going to experience. What else?
Making sure we have the appropriate medications ordered.
Yep, yep. Anything else? We might want to make sure that the family and the patient are both aware that this could happen at any time and that it would be a catastrophic event. So if there's any unfinished business or conversations, they should be happening as soon as possible. When we think about goals of care for somebody like this, what are some of the questions we might be asking, or what are some of the things we might need to learn to make a decision about goals of care for this patient?
What's most important to them?
Yeah. Has anybody ever spent any significant amount of time as a patient or family member in an ICU? Oh, that's a good one, Katie. Religious and spiritual needs or influences. Yep, we definitely need to know about that. We might need to just know, do you want to stay in the ICU or do you want to be transferred elsewhere based on what she wants for her goals of care?
My daughter works at another hospice. She works in Owen Sound, and they had a catastrophic event and the fellow wanted to be outside. So they've got, in Owen Sound, they've got these nice sliding doors that you can just push the patient out in their bed, and that's where he passed.
And that's awesome that they had that knowledge ahead of time, that when something started that they could follow through on that. Great, thank you, Chris. What kinds of orders might the nurse need to adequately manage this patient in a catastrophic emergency? Can be just the types of medications or the actual order you would like to see, depending on your scope and knowledge.
Something for pain,
Yep,
morphine, midazolam.
yep, something for pain, something for sedation. Yeah, in this type of situation, I would want to see a very generous dose of midazolam available so that she could be sedated quickly. Exsanguination is typically not a painful process, depending on the source of the bleed, but it can be very, very distressing for the patient when it starts until they lose consciousness. Yeah, IM or even sub-Q or IV, depending on what access you've got. And yeah, a good healthy dose. Thanks, Amanda, for putting that in the chat. Our second case study. But before we move on, anything else to prepare for this likely event?
Dark towels.
Yeah.
Yes. Dark towels, disposable absorbent pads, and not out in the hall if possible. In the room, close at hand. A privacy screen if it's a shared room, very important. A catastrophic bleed is quite traumatic to witness, even if you're prepared for it and even if you're a healthcare provider. So being able to block the site from other people who might not want to see that is important. It's also important to let the family know that they can leave the room when it happens. They don't have to stay if they're not comfortable with witnessing it also. Okay, our second case study. He is a 79-year-old man with a history of lung cancer with tumor progression into his trachea. He's at a residential hospice for end-of-life care because of distressing dyspnea and pain that was poorly managed at home. He is currently being treated with palliative sedation for the dyspnea because it became intractable. He's on a continuous midazolam subcutaneous infusion, and he's on routine hydromorph with breakthrough doses of both for dyspnea and pain. His goal for this treatment was to get to a sedation score of RASS -4 to -5, and that was obtained and had been relatively stable for a couple of shifts before this evening. 2 o'clock in the morning, the wife was at the bedside quietly reading when suddenly the patient awoke in severe respiratory distress, gasping with a frightened and anxious look in his eyes, and she panicked, rightly so, and yelled for help. So, this patient already has a midazolam pump in place for sedation. What can we do to alleviate this new distress? And that might depend on your location and place of work.
Would you give some Nozanan while you are waiting for your increase in midazolam to kick in to put him at the RAS he needs to be at?
You could, but Nozanan can take up to an hour to
Oh,
start being effective.
right.
So not the first go-to, but it might need to be an ongoing thing if this is not a catastrophic airway obstruction.
Okay.
I see phenobarb. Yep. In a hospital, you're going to have a lot of access to you're going to have access to different medications like fentanyl or phenobarb or ketamine that might be appropriate to use in a situation like this on top of the midazolam. A clinician bolus of midazolam. Yeah, you're going to get that bolus in according to the pump. I will say that in this hospice situation, there are catastrophic emergency orders for midazolam, but they were discontinued when the pump was started because the pump was expected to be a sufficient amount for sedation. And it's 2 a.m. The PSW answered the call bell initially in this situation, and the nurse was experienced enough that she grabbed additional medication both midazolam and hydromorphone, along with a few other things, and took everything into the patient's room while calling the doctor. They got a verbal order to give additional midazolam on top of the bolus from the pump and the pump's amount, and it was given stat along with an additional dose of hydromorphone stat. So the patient ended up receiving 30 milligrams of additional midazolam before he was calm and sedated to a RASS of -4 to -5 again. How do you calm a patient and their family at the same time while also recognizing that it's the middle of the night and staffing is not as robust as it is during the day? In this specific residential hospice, there was only a nurse and a PSW at this time of night. What can we do?
Have one stay with the patient and make sure that they're settled and calm, and then maybe the PSW can take the family member out, calm them down, take them to a kitchen, distract them for a bit.
Yeah, definitely. Any other thoughts? What do you do if you're the only staff and the call bell goes off? Like they tend to when you're busy in a room in the middle of the night. What would you do then?
Too bad it doesn't have an internal call system. So you can at least call the room and say, I'm busy.
Yeah, that would be the perfect world, wouldn't it, Kathleen, where you have the ability to talk into other patients' rooms.
Yep, would be nice.
Were you going to add something, Chris?
I'm gonna just add it, like if I was desperate, sometimes giving a family member a little job can be helpful, like more towels, or they might not want to leave the room, but just employ them if it's appropriate.
Of course, of course. And it would all depend on that family member, right? And how well you knew whether that suggestion of, could you do whatever the PSW is doing while they run to answer that call bell? If you have to, you ignore the call bell. Yeah, communicate with the spouse that somebody's going to leave, but they're coming right back. Luckily, in this situation, there was nobody else in need of any assistance or attention or medications during this time. Both staff were able to focus on this patient and the spouse completely. Another thing that could happen is if there's other family members present in other patients' rooms, then we could get them, if it's safe and appropriate, to help those patients with what they need, whether it's toileting or just reassurance and distraction until the staff can get in there and do what they need to do. No matter what, you're always having a calm presence, reassuring everybody that's involved, and making sure that somebody's explaining what's going on, what's being done, and why we're doing it. What should be done after the patient dies in a situation like this? And the gentleman did. After 30 minutes, he did pass away.
Providing comfort to that family.
Yep.
Debriefing with the PSW.
Oh, yeah.
Even debriefing with the family if they need it, but just kind of holding space.
Yeah.
Asking them if they need to call anybody else in.
Yeah.
Making sure that the wife, if she does go home, somebody drives her or can come and get her.
Exactly. In this case specifically, yeah, resources for the spouse, definitely. Yeah. And a clinical debrief for sure. It can be very traumatic to staff in a situation like this. In this situation, there was a follow-up and a review of the policies and procedures to make sure that the standing orders specifically said that even if a patient is on a midazolam pump, that the catastrophic event orders are not discontinued. That allowed registered staff to have that clinical judgment to use those in a situation like this without having to call the doctor first. So our last case study is an 82-year-old male with a history of cancer of the larynx with an existing trach opening and no ventilator support. He's at home for end-of-life care with daily nursing visits. He completes independent self-suctioning because of mucus, and when the nurse is visiting Tuesday, he reports a few streaks of red blood in the mucus. Health teaching is completed that day about the risk for a bleed from his airway, and the patient is completely understanding of the risk and is made aware of what the course of action should be, and a plan of what the family will do if it happens when there's nobody else in the house is started but not completed. 2 days later, the nurse is visiting, and the patient is completing his suctioning while she's there, and the son and grandchild are also present, and suddenly there is copious frank red bleeding. The son and grandson panic, and the patient panics. So let's think, what are the possible catastrophic events that this gentleman is at risk for? And why? Why is he at risk for them?
Hemorrhage or airway obstruction because of the bleeding.
Yep. And why is he at increased risk for bleeding, Kathleen? Do you know?
Can you go back a slide?
Yep.
He has cancer of the larynx. He has that trach.
And likely
he's
had
not-
radiation to the area too. Good. So in this situation, what would the nurse's responsibility be?
Remain calm.
Yes, number one, remain calm. You can panic in your head and you can panic afterwards, but you cannot panic in front of the patient and the family.
Ask the son to get medications or whoever is there to help you.
Yep. Yeah.
Get the grandchild out of the room. Get them to do something different.
Yeah.
Delegate.
You got them all. And remember, we're not calling 911 unless that's a part of the patient's goals of care. For the son and young grandchild, Kathleen kind of touched on it, but we definitely want to make sure that at least the grandchild is leaving the room and the son knows that he can if he wishes to. What if the PSW had been visiting instead of the nurse? Would we do anything differently?
I think same thing. Obviously, they can't order medications, but remain calm, support the son, try and support the child and get them distracted, but stay with client and make sure that they're supported and then call the nurse on call.
And, fetch supplies for the family because they should be the ones doing the administration of medication if that's been what the plan is.
Yeah, if they have that SRK kit.
And yeah, and Kathy put in the chat, hopefully they've been informed about this. Yes, unfortunately in this case, it was only 2 days between when the bleeding started and the education started and when this situation happened. So it had been started but not finalized in terms of who was going to do what and when and how. Let's pretend the family is totally on board with the plan and they're comfortable with everything. What would the family do if they were alone when this happened with him?
Dark towels, left side lying position, administer medications.
Yep. And most importantly, written instructions for them to follow. They don't have to remember what to do in an emergency. And what do you think appropriate goals of care or intensive interventions would be in a situation like this? Would it be appropriate to call 911?
Depends what their conversations were previous.
Yeah.
And if they've been well enough educated on the circumstances, then I don't think so.
Yeah.
But comfort would be the main goal.
Yeah. In this situation, it was a catastrophic hemorrhage with no chance of survival. We have to remember that exsanguination is distressing and anxiety provoking, but once the patient loses consciousness, they're unaware of everything that's happening. The goal should be to administer sufficient medication to achieve rapid onset of deep sedation, along with emotional and physical support for the patient and their families. So that was good. You were good on those questions. There's just a couple of the resources we used. There's the QR code. We just want to say thank you again for coming to our presentation. Please use the QR code to complete the survey. Amanda has put our next session registration link in the chat, and it is about palliative care in the corrections system, if I remember correctly, right, Amanda?
You are correct. That's right. We're looking forward to it. It's a great presentation. I've had the opportunity to listen to this one before, and our guest that day is Louise Frazier. She's a bereavement services coordinator, and she is an excellent presenter as well, just like these guys. Thank you all so much. Thank you, Laura. Thank you, Linda. Great presentation today, and keep your eyes open on your inbox because there's lots of resources coming your way.
Thanks for joining, everyone.
Thanks, everybody. Have a great day.